Thanks to everyone for joining our Q&A session today. I'd also like to welcome along Dr. Alan Bonder, who's joining us from the US today. Thank you so much for taking the time to be with us again. We really appreciate it.
Thank you, Mo. Thanks for having me again.
And just before we start, I just wanted to remind the patients that the Q&As don't take the place of a consultation with your own clinician. We're aiming to provide medical advice. We're aiming not to provide medical advice, but to provide general medical information. Also remember as well, if you're joining us on Facebook, that's a public forum, and you can join us here in the Click meeting room if you want a bit more privacy here with Dr. Bonder and I. I'm going to get started on the questions we've had sent in. We've got quite a list this week. It's been a few weeks since we've had a Q&A, so that's great. So we've got quite a lot of questions. And if anyone who's with us live, if you want to put a question into the Click meeting here or into Facebook, I'll keep an eye for those as well. So the first question's around a supplement that they've been advised is great to use alongside Urso. Now, I'm not going to attempt to pronounce it. Do you have it there on your document? It's NAN and then acetyl L.
Mm-hmm.
Do you get it
Yeah,
there?
I have it.
You got it there? Yep. I don't know if I'm pronouncing that right or what the supplement is. It's not something that I'm familiar with.
I mean, again, I think, supplements with PBC, there's no data. So I think if you are responding, if that person is responding to UDCA or URSO, I think that should be enough. But again, I want to just make sure that people are aware and careful that supplements can really damage your liver and can really put you on the other side. So we've had a lot of issues getting patients getting supplements and actually needing a liver transplant from acute liver failure. So again, my advice is to stay away from supplements because they're not properly regulated.
Good, thank you. So I think it's a really important thing to mention. So we have a patient who's got in touch about her daughter-in-law. So when a patient on the transplant list is advised there is a liver available, what will the doctors have to check to ensure it's good enough for them?
Oh, that's a very interesting question. So I think that, and again, I don't know where this person come from. So I'm going to actually talk a little bit about the experience in the US is. So when we do have a liver, we call the patient, we explain the donor, characteristics, and then we said it's a good match for you, and then we tell the patient to come in. But again, I think this forum is a little bit more than for PBC than actually for transplant.
Well, I think it was just to give an idea of when a patient does get a call for transplant, what would be the things that are checked over in the liver. I think she's just wanting to have awareness of it so that she can support her daughter.
So I think the most important thing is when you get a call from any physicians that there is an organ available for that person. I think, I would say the most important thing I think is the shocking news, but the most important thing is just taking a deep breath, saying that, that's our time, and then, just asking the right questions is, some people ask the donor age, some people ask the donor characteristics. There's different types of liver donors. But I think the most important thing is physicians think this is a good match for you. I think, that organ is a good organ for your daughter. And I think the best thing to do is take a deep breath, get your stuff ready, and then get to the hospital. So get the process going.
Be led by the advice. That's great. Thank you. We have a patient who the diagnosis hasn't been confirmed yet for PBC. Their ALP was at 1200. And they were put on Urso and it lowered into the 500s. In their last blood test results, it's back up to 1200. Could it perhaps be something other than PBC?
I mean, I don't know what the diagnosis has not been confirmed. So I think that's a very important thing to do. If there is a positive AMA, that person has PBC and that person is not considered a proper responder to Urso, and then other types of therapies should be considered. But if, the diagnosis of PBC is still in question, there is other things that I would advise, like getting an MRI to make sure that the bile ducts are not issues. There's some medications. So again, there's a lot of different things that could cause the elevated alkaline phosphatase. But I think at this time, I need to know exactly what that diagnosis of PBC is uncertain at this moment.
Okay. There's a question around stage 4 and the patient being scared and asking about prognosis, but I notice a few questions down. There's also another question about a patient saying they're stage 4 and will they automatically require a transplant. So I think potentially we can maybe put both those questions together if you could take that.
Yeah, I think this is a great important kind of things to understand, Mo. I think stage 4 equals cirrhosis, and cirrhosis does not, and I would say it does not equal transplant. So we've had a lot of people who are walking around in the world who have liver disease, cirrhosis, who they don't know they have it until they have symptoms. So, the symptoms that basically making you start thinking you about a transplant is when you become jaundice, you're yellow, or there's fluid in your belly, it's called ascites. Those are the symptoms that we are concerned that could actually um, trigger a kind of a new transplant evaluation. What I'm saying is if we can actually keep the patients with compensated, and this is kind of the most important word that's out there, compensated, people they look like completely normal, but they have liver disease, they can have a pretty good kind of life expectancy. So, I mean, if you look back the data then a few years ago, people who have cirrhosis, who are compensated, who have properly treatment for their conditions, for example, in PBC, if we can get their control, can get their alphas under control, we can get their bilirubin under control, get their symptoms under control, we can give those type of patients good amount of quality of life. So a stage 4 means that there's cirrhosis, but a stage 4 does not give you an automatically transplant evaluation. That means that you unfortunately had a lot of injury to your liver for any type of those diseases, and now you actually need to have other types of screening. But I think the message is, one is once you have it, what can we do to prevent more decompensations? And there's two things I tell my patients. One is you develop cirrhosis, no matter what the etiology of the liver disease, you are at risk of liver cancer. Make sure that you get screened because that's something that we can treat early and we can give good treatments. And the other thing is get screening for varices, big varicose veins in your esophagus, because if we get them treated early, we can prevent them from bursting and bleeding, or we can do things to do for them. So this is the things that we should be doing to make sure that the quality of life or the amount of life, the expectancy of that patient is actually preserved. I don't know if that actually answered both of those questions.
Yeah, no, I think it did. Yeah. I wonder if you could just say a bit more about what's the difference between compensated cirrhosis and decompensated cirrhosis, because it's a term that's often used as well, just to identify the differences.
That's a very, very good question, Mo. I think compensated is people who look completely normal without, but they have the presence of cirrhosis, either by elastography, FibroScan, or a biopsy, or other findings that showed cirrhosis. So that's a compensated patient. And a decompensated is a patient that I just explained to you when all the signs and symptoms of liver disease appear. If you develop fluid in your belly, ascites, if you develop fluid in your legs, if you develop a variceal bleed, bleeding from those varicose veins, or confusion, or in this, for example, in the setting of PBC, symptoms can, be kind of signs of decompensation. So, for example, severe itching when you're yellow. I mean, I know itching can show up even when you don't have cirrhosis, but if you have itching and you're yellow, I mean, that's something that should be brought to your clinician and make sure that you don't have any, advance in your liver disease.
Great, thank you. We have a question around what does coarse echo texture mean?
I mean, they're very tough today. So I think coarse echo texture. So when we actually evaluate a patient with liver disease, one of the main kind of tests that we do, it's a kind of liver ultrasound. And the liver ultrasound gives you some type of how the, and then it's like a texture, right? And then the way the radiologist will report that to us is they can say an increased echo texture. So for example, a steatotic liver can give you an increased echo texture because fat can light up more in ultrasounds. That doesn't mean that your liver is sick, so meaning that the liver does not look normal. So that sometimes could be a sign that there is something else happening in the liver.
Great, thank you. Just want to say I have a strange man called Robert Gish saying hi to you on Facebook. I just thought I would pass that on. Next question is, what is secondary PBC?
That's a good question. I don't know about secondary PBC. So I think there is primary and there's secondary biliary cirrhosis. So primary biliary cholangitis is the autoimmune liver condition that you need an elevated alk-Phos and a positive anti-mitochondrial antibody. And secondary biliary cirrhosis is when someone has chronic obstruction of the bile ducts that leads to the scarring of the liver. For example, some people who had surgical complications, for example, they ligated the common bile duct, or they have other issues, they cannot drain properly the bile into the intestines, they can develop secondary biliary cirrhosis. But again, I want to make sure that we understand the difference in terms. They changed the terms to primary biliary cholangitis because not everyone develops cirrhosis, but secondary biliary cholangitis or cirrhosis can start the same process. You can develop inflammation, you go into develop scarring, and finally you will go into develop cirrhosis.
Thank you. We have a patient who has other autoimmune conditions. They don't know what those are, but they say they've been avoiding other medications. It's a really quite a general question, but they're asking what autoimmune medications are safe to take when you have PBC.
I think most of those medications, any medication that treats any other autoimmune condition, it's safe to use in PBC. So the only thing that we need to be careful when those patients develop cirrhosis with the compensations, for example, there's certain medications for rheumatoid arthritis or lupus. For example, methotrexate is one of the big ones that comes to my mind that you need to be careful to make sure that there's not enough scarring or there's not enough fat in the liver. For example, other new biologics, I would say like Remicade comes to my mind, or Humira, and all the other medications that we use for inflammatory bowel disease. When you have an autoimmune liver condition, you want to make sure that they follow closely the liver test, because sometimes those medications can trigger more autoimmunity in the liver. But again, they are safe, and then again, we need to prioritize that we need to treat those diseases because we want to make sure that we treat those symptoms properly.
Yeah, thank you. Does lower back pain around the hip bones have something to do with PBC?
Again, good question. The answer is the most likely explanation is not, but again, there is a condition called osteoporosis or osteopenia, which is weak of the bones, that could be kind of related to PBC. And in those cases, compression fractions or even those type of symptoms can be a sign of this kind of conditions. So anyone with a PBC diagnosis should get a bone mineral densitometry to make sure how strong the bones are. And if they don't have that conditions, it's very unlikely that is related to PBC.
Okay, thank you. We have a patient who was diagnosed in January with PBC due to raised levels in AMA. No symptoms, no itching, and the radiographer at their last scan said the liver was perfect. I have been prescribed medication which I have not taken. Can raised AMAs mean something else? I had COVID a couple of months ago before the test. Can this give a false reading?
Awesome question. So, to be kind of like, I'll say purist, the diagnosis of PBC, it has to have 2 out of the 3 following, right? So you need to have an elevated alk phos, 1. Number 2, an elevated or a positive anti-mitochondrial antibody titer. And then right now we are looking at titer, specifically more than 140. And finally, if we don't have any of those 2, then you need to have liver biopsy findings of primary biliary cholangitis. So if you get 2 out of those 3, you have a diagnosis of PBC. So some people get tested for AMAs when they have abnormal liver test. There is maybe a 5% cases where there could be false positive, but sometimes what it means is 1 out of 5 of those people will end up developing PBC. So there's 2 things that they can do. One, if they have a normal alk phos, they can continue to follow the liver test closely with their either primary care clinician or even hepatologist. And if they have seen elevations of the alk phos, start treating with the ursodiol, or if they want to start treating with the ursodiol, which is a pretty benign medication, that's another option. So again, it's a great question. I think what we know now and what we know in the past is patients, AMA is a very sensitive test to PBC, and then most of those patients will end up going to get a diagnosis of PBC.
Okay. The patient doesn't mention about the ALP, so I think that would be a good thing to check with our doctor to ask what our readings are for that in terms of our ALP. That's great, thank you. So we have a patient who's had high liver enzymes for a few years, and due to that, their specialist has put them on Urso and diagnosed PBC. Liver is good, 6 months on Urso, and all enzymes back to normal except ALP. In the chart, there was a comment about possible secondary PBC, was tested for AIH, which was negative. I think the concern is, could they be misdiagnosed, and what else would cause the liver enzymes? No mention of the AMA, which is interesting after what we've just been discussing as well.
Yeah, I mean, I think it's again, another, today is tough questions. Not everyone who has abnormal liver test who has a positive AMA will end up developing PBC. Again, remember, you have to have the right clinical features for that. So what my advice would be is to look for an AMA antibody, anti-mitochondrial antibody, look at the liver test and see, if the liver biopsy shows findings of PBC, then the patient has a diagnosis of PBC. So I think it depends on the right clinical context.
Great. And then we have a question around urso dose. Patient who's been on urso since November last year, weighing 61 kilograms and was prescribed 750 milligrams of urso a day. I've been told by others with PBC that my dose is not adequate and I should be on another 40 milligrams daily. Sorry, that doesn't make sense, the bit in the question there, but I suppose the question is, could it be that they're looking to see if there's a response positively at 750 before it's lifted up, or should they ask about having the dose increased?
That's a great question too. So, I mean, I think it's very important to understand that the properly dosed ursodiol is between 13 to 15, 13 to 15 milligrams per kilogram divided in a day. And again, if you can go from 13 to 15, if you look at by 61 kilograms, 15 should be close to 1,000. If you go to 13, it should be around 900. So yes, I think that patient is a little bit underdosed, but if the liver tests are normal and they're responding to 750, I think there should not be any problem to keep going at 750. But if the patient's alk phos is still not going back down, then I think the main reason is that they're not properly adjusted for that person's weight.
But I love that they're aware that what the dose, that they may not be on the correct dose, which is really good. It's really good for patients to have awareness of that, and that if their weight fluctuates, that they need to consider that. So we have a patient who's had PBC for many years and it's under control. Recently their cholesterol has risen and they also suffer from gripping pains in their abdomen. Should they see a specialist? And her GP has mentioned about going on statins. Is that okay when on urso?
Yes, I mean, we are seeing a lot of people. So one thing that's very important, PBC, when PBC gets diagnosed, we see patients' cholesterol being really high, and this is why. This is the answer to this is because of the way we metabolize the cholesterol. We use the bile acids, and when you have PBC, there's basically a difficulty kind of using those bile acids and kind of metabolizing those bile acids. So it's not uncommon to see patients with PBC with elevated total cholesterol, HDL, which is the good cholesterol, and also the bad cholesterol. So when you see that patients with PBC, they're not at increased risk of heart attacks unless you have any other risk factors, such as diabetes or blood pressure or even family history. In those cases, if you need to use a statin, it is perfectly okay to use that. We have published data in the past, maybe close to 600 patients using statins, and there was no really significant harm. So no, the only thing is we need to be aware that statins can basically elevate liver tests. And then in those cases, is a concern that you have an overlap syndrome or statins or something else. So I think that's why it's so important to continue to follow with your, different physicians to make sure they're actually evaluating closely to make sure there is nothing else developing in that person.
It is a question we get quite a lot about statins and cholesterol. So we have a patient who's asking about PBC and B12 deficiency. She's been diagnosed with both and wondered whether there's any connection between the two.
I mean, there is, pernicious anemia, which is an autoimmune condition in the stomach. It could be. I don't think that's kind of like the top 5 autoimmune conditions are linked to PBC. But I guess if you have one autoimmune condition, you are in increased risk for another one. So I think definitely there is a possibility, but I don't remember seeing that's a very kind of like strong link to PBC.
Okay, thank you. We have a patient who's watched one of our webinars where HRT was strongly recommended to be used in patch form because the estrogen in tablet form would be a big hit to the portal vein. GP says they no longer make the combined patch in the strength that they need and has recommended estrogen patches and progesterone in tablet form. Do you know if that would be acceptable?
It depends on the reason why they're using. So I think, this is a kind of we need to kind of personalize that question. I don't know that patient's cancer risk factors. We know that hormonal replacement therapy, it's linked to breast cancer and other types of cancer. It's linked also to blood clots. But also we know that helps, for example, with osteoporosis and osteopenia. So I don't know. I mean, I think you need to make sure that you check with your physicians and making sure this is the right indication to be using HRT if needed.
I know where the patients sometimes encourage their GPs to speak direct to their specialists as well, so that they can, rather than be go-between, can have that conversation direct and say the patient's a bit concerned about using this because of our liver condition. Will it be okay?
I think one very important thing is we need to, this is not a kind of a black and white answer. Sometimes we need to basically just weigh the risks and the benefits, If the weights, if the risk outweighs the benefits, then I think it's really, we need to kind of look back and say, this is the right thing for me. But I think you need maybe answers from different specialists to understand this type of risk and this type of benefits to take the right decision.
And I think because each patient can be different as well, and as you say, it's important that if something's going to help with their quality of life, that's considered as well. So it has to be weighed up on an individual basis.
Correct.
The word supplements mentioned in the next one, but I will go for it. I've had PBC for 10 years, take Urso for this. Recently developed osteoporosis in their spine and hip. Was prescribed medication for this, but I've not wanted to take it due to varying side effects that could occur. They've started HRT, which believe may help. They've also been looking at collagen supplements called Bone Balance. Please let me know if you've heard of this particular supplement or aware of any contradictions with PBC that I should be aware of taking collagen supplements.
Again, I am not a big supplement person. I think that person should be taking what we have, all the new medication. We have a lot of new medications for osteoporosis. Even the old medications, we know they work. So I would advise against supplements and really talk to an endocrinologist who is specialized in bone densities to actually get the right treatment. Because what we know is people who don't get treated, they are increased risk of fractures, and that will really affect the quality of life. So I think the sooner you can get into treatment, the better. One very important thing is, I don't know if that person smokes or not. So smoking is one of the biggest risk factors for osteoporosis. So we'll recommend not smoking, doing some exercise, and then trying again, see a specialist for bone densities so they can actually get into the right treatment as soon as possible.
I think there's been a wee bit of a recurring theme today as well, where patients are saying they've been prescribed something, but they're a bit worried about taking it. I think it's really important that they share those worries with their doctors as well. If they've got a valid reason why they can discuss that with their doctor, but just to come home and not take it when potentially it would be helping, I think it's just really important that they discuss that with their doctors on an individual basis as well.
And again, I think, reading the side effects can be scary, but I would say those medications, when you get side effects, which is very unusual, the things could be addressed, changed, and then, try for a different thing. So I think it's very important to just not taking what you were prescribed, but ask the right questions, or just talk to your physicians about your concerns and see if there's any other options for you.
Thank you. So this is a question that we've actually heard from a couple of sources, and I thought I would pop it in for you today. There's a patient who had got in touch with us to say that there had been a rumour that in China has been using Urso because it was thought to protect people against COVID, and this has then caused a shortage in supply worldwide. They've been taking Urso for 14 years and never had a problem getting hold of it before. Is it something that you're aware of?
I don't, and I have never heard that, Urso
We hadn't either, no.
COVID, so no. The answer is I have never heard about it, and I don't have any information about this, unfortunately.
Okay. I think what would be, because we've heard it from a couple of routes, I think it would be good for us to understand where the supply problem might be, and we can look at it into a bit more detail from that. We've also had a similar question around the difference between licensed Urso and generic Urso. We've heard from patients in the US of a company there who did produce generic Urso, which is closing down. Just to see if you were aware of anything about that, and could maybe talk a bit about the differences between the licensed and generic.
I mean, I think the Urso commercialization, I would just use as this word, it's very tough. In the US, we only have one company who is basically in charge of making Urso. And unfortunately, because of this monopoly, the expenses of Urso has becoming higher and higher. So fortunately enough, there's some kind of healthcare systems that help patients to try to get that Urso cheaper so they can basically get the right treatment for their disease. So what you're referring, though, is there's a medication or the brand names. For example, I don't know what the brand name in the UK, but there's a brand name. And then when the brand name has, the patent has been released, and they can do different types of medications or other names. So that's what the difference in medications are. But right now in the US, we only have one company making Ursa with 3 different doses, and then that's the only thing we have available. Unfortunately, I don't know the UK situation, Mo, but that's where we stand in the US currently.
Yeah, we have Professor Jones on next week, so we thought it would be a good opportunity to ask you this week, and then we'll ask him from the UK perspective next week as well. We actually also had I was just trying to reply to see where this patient is, but they've commented on Facebook to say there was a shortage of 150 milligram or so, and they had to go without for 5 days. If you could just let us know where I tried to reply to that, but I couldn't. If you could just let me know what area you're in, I can update on that as well, and we can look into that in a bit more detail. So on you're going some today. We're nearly through these questions and the list that we've had in, and that's a lot we've had in for a while. I think you need to give Professor Jones some tips. If this was his list, we'd still be at it about 3 weeks into it. So so this has been brilliant. So we've got one last question here that I'm going to read from the information that had been sent in. So if any patients have got any other questions for us, please start popping them in the comments for us and we'll pick them up. So we've covered this a little bit before, but it's a patient who's got backache and was referred to a rheumatologist and diagnosed with osteoarthritis in the facet joints. Recent blood tests were positive for several scleroderma antibodies. They were told this was due to their PBC, and they shouldn't need to worry about having another autoimmune disease. Is that valid?
Yes, I mean, for example, the kind of interesting thing about scleroderma and PBC, they do share the antibody. We look at the anti-centromer antibody. It was one of the type of antibodies both diseases shared. So yes, so again, as I said before, an autoimmune condition puts you at risk for another one. And when you look at, again, what the other autoimmune conditions can be kind of linked to the PBC, so CREST or scleroderma could be one of them, so I think it is important to basically consult with a rheumatologist, make sure that the diagnosis was properly made, and then after that start on the right treatments. But yes, this is definitely a link that we know it's out there.
That's great, thank you. The patient who was reporting the shortage of Urso, it's in Northern Ireland, but she had also been in contact with a patient who'd been in Australia. So so that's great. So I'll take a note of that. So if there's any other patients that are aware of any shortages in other areas, please reach out and let us know, and we can start to look into that at the foundation for you. Right, so that's all our questions that we have that have come in today. I'm just going to have a wee look and see what we've got coming in live. So we have a patient asking, since a drug for NASH has been approved for fibrosis, is there a drug for reversal of fibrosis in trial for PBC?
Great question. Wow, they're really going all over the board today. So, there is no kind of drug that is, there is 2 new drugs getting approved in the US, I don't know in the UK, in the 2 to 3 month span. And it's really actually an amazing news, because every time I'm here answering questions, I tell you guys, there is good news, something will come up. Well, yes, something will come up in 2 months. So we'll have 2 new medications approved for PBC. When you look at the studies for PBC, the studies are being for 1 year, maybe 2. So there hasn't been enough time to see if there is kind of decrease in the scarring or the fibrosis, or what specific question. But I'm sure we will look into this in the future. What we know is that we actually get your alk-phos down, get your bilirubin to normal, within normal limits, then we know that the scarring is less likely to occur and then less likely to progress. But again, the actually specific question that slows down fibrosis progression is not being answered in all those studies yet. But we will come back to that question soon, and hopefully with a good answer.
Great. So I have questions popping in now. Just give me 2 seconds to get the next one for you. So we have patient who's read some comments on PBC forums that some patients experience pain in the liver area. They also experience a dull ache, sometimes a stabbing pain in this area. They have PBC with compensated cirrhosis and a gallstone. Do you think this pain in the area could be linked with PBC?
Wow, they're going again fine. So yeah, so I look at the symptoms from PBC. I would say the top 2 symptoms right now are itching and fatigue, but there's a third that's coming, and that's actually abdominal pain. And, abdominal pain could be from a different variety of reasons. So I think as clinicians, we need to make sure that we rule out other things. So we looked at stones, other things, for example, gastroparesis, celiac disease, which can cause pain, which is very common with PBC. And once we ruled everything out and we really don't have a really good explanation, then we really say we have to blame it on the PBC, and we'll try to treat it with pain medications and some other type of issue, other type of medications or measurements, so we can actually improve that quality of life of the patient. But yes, I think the third most common symptom in patients with PBC right now is actually pain in the right upper quadrant in the liver area.
Great, thank you. We have a patient asking about dry eyes, just if you could give us a wee bit of information about that. If they say they use a mist spray and get dry mouth, so drink water, but are there any other tips that might help with that symptom?
So it's very common to see patients with PBC, what's called Zika syndrome. And Zika syndrome is basically dry eyes and dry mouth. And then I would say 20-30% of PBC patients will have this type of symptoms. So what I do is, again, hydration is very important, and then some eye drops that you can use to make sure that that sensation of dry eyes will go away.
Just to make sure that patients are telling their doctor about those symptoms as well, because there's something potentially that can help for that too. Which is great. We have someone asking about their daughter has AMA-M2 but no high ALP. However, their consultant has her down as they've given her a PBC diagnosis. They're thinking it shouldn't be in her records as no treatment is given and the ALP is currently at 70. What would your advice be?
Great question. So I'm going to take a step back. So we know that PBC is a genetic condition. So for example, if you look at female predominance, I actually tell my patients, if you have a first degree relative who's a female gender, they should be screened. And this is what we're going to encounter, right? So we have patients who have normal liver tests who have a positive AMA. And as I said before, two things that can happen. So that patient is definitely either increased risk of having PBC, and two things we can do. We can follow their liver test closely now, because there is, at least right now, with a positive antibody, there's a 17 to 21% chance that they will develop PBC. Or you can take the ursodiol to keep the liver test normal, or you can wait until the liver tests are abnormal to start taking the ursodiol. And both these options are really good options. So, but yes, I think it's important to actually counsel our patients with PBC that there is a genetic predisposition, and then actually first we can realize specifically females should be screened for PBC because just the things that I just explained to you.
That's great, thank you. I think that's us caught up with all the questions we've got coming in live, and we've still got plenty of time, so please let us know if there's any other questions you would like me to ask. I wonder, Dr. Bonder, if we touched on it earlier about the new treatments that are coming along. I wondered if you just wanted to spend a wee bit of time talking about that. I know a lot of our patients are really interested to hear about the 2 second-line therapies that are coming along.
Yeah, so yes, Mo, for sure. I think so let me go back in history, right? So since the 90s, we only had ursodiol as basically the only therapy approved in the US and I think in the UK to actually treat patients with PBC. And what we know is that 60 to 70% of those patients will respond properly. And when we say respond properly, means that their alk phos will go back to, I would say, less than 150, 160. So we had a lot of patients, out there who actually were not getting back to normal. We're not getting back to what's called response to therapy. And again, in 2016, 2017, obeticholic acid was the second medication that actually was studied and then showed really significant improvement in the alkaline phosphatase. And since 2017, 2023, even 2024, we just got 2 major publications. One is seladelpar, which is a PPAR delta agonist, and then the other one is the elafibranor, which is a PPAR alpha and gamma, who basically work for getting the PBC under control. And what we've shown in those studies is those patients who did not respond now are responding. So right now we have 2 approved therapies, 2 that will get approved in the next couple of months. But the kind of interesting things, we have another kind of, I would say, another round of 6 to 8 new medications that are still in the pipeline and that will come up to actually help us with patients with PBC. So I think what I see for the future is I see a lot of patients getting a mix of different medications to try to get them to normal. And I think it's not, we're not talking about like, 20, 30 years. I think we're talking about maybe in the next 2 to 5 years, different, patients with different profiles, and depends how the profiles will be, we'll rest stratify them and we'll tell them, you will need to take 2 or 3 medications to get your PBC under control. And I think right now is, I think you use the word second line therapy. We don't know they're going to be second line, third line, extra line. So we don't know the word that we'll be using, but we know that actually those medications will help significantly. And finally, I think those 2 medications, and there's a combination of ursodeoxycholic acid and bezafibrate, which is combining the 2 different receptors together. And there's a clinical trial undergoing now. So my hope is also we'll have that type of combination therapy in the future, in the next, I would say, year or so. So again, we will have really good, really new medications to get PBC under control. And again, I don't know what are the FDAs or the regulators in Europe are going to say. We're going to make it call it second, third line therapy, or salvage therapy. But what we know now that those medications will get PBC under control for most of the patients.
And I think looking at urso being our first line treatment, but then looking at all these other new treatments possibly being options for combinations for different patients as to what they might need. And I think it just opens up a range of options for patients, doesn't it? If they're not responding to something that's available, there are now not just potentially 1 or 2 things to try, but there could be multiple things for patients to try, which is great news. I was going to ask as well just about, we know there's a couple of treatments getting looked at in terms of itch as well now. So it's also good to see clinical trials for treatments for symptoms of PBC, and not just for managing quality of life as well, and one potentially for fatigue, which is amazing. But we have had a question about itch, but more of a comment really, and I just thought it might be an opportunity for us to have a bit of a chat about that. So patients asking, is itch feeling of ants crawling like a sting, that they have that with PBC? And that's a term that patients will use a lot to describe their itch.
Yes.
But there's quite a variety of terms that patient would use to describe their itch, and it can be quite different patient to patient.
I think let's just take a step back though, because I think something that we are forgetting to ask. I mean, some people, they have the stigma of itching and they don't want to kind of either rely to that to their clinician. So I think this is a symptom of PBC. We know in the physician side, we don't ask enough about itching. So I think in both sides, we need to make sure that comes up, because if it does not come up, that doesn't mean it's going to go away alone. That means that, we won't be able to address it and we won't be able to give her treatments properly. I think right now we are seeing a lot of new treatment options to get the disease under control. When I say disease under control, I'm meaning their liver tests get under control. We follow a lot of liver tests, but, for the first time, we're seeing also symptom control, as you mentioned, Mo. So, for example, the Seladelpar part just showed that the itching was a really major kind of like, breakthrough in science, saying, okay, right now, not only we're treating the disease, now we're treating the symptoms. So I think right now it's so important to make sure that we rate our symptoms, right? For example, what we have available now. So we know the ursodiol does not treat the itch. We know that we need to use other medications to treat the itch. And there's other medications in clinical trials, and hopefully will be approved soon, that really a night and day when you see itching in patients in your clinics. So again, I think it's important to try to address it. We need to make sure that we relay that information to your clinicians. And once we have or we rate the itching, then we can give different type of treatment options. So for mild itching, we can start with antihistamines, just cutting your nails, just basic things to, all there are other types of medications, even in clinical trials, to try to get the itching under control. So I think it's so important to make sure that this information gets out there, because itching is such an important symptom that we need to get it under control.
Yeah, and there's quite an extensive list of different treatments for itch on our website if anyone's interested in the detail of that. And also just to say, I think if we have a patient who's suffering really bad from itch, that'll also affect their sleep as well. So their sleep hygiene will be off anyway. And then if they have fatigue as well, that's possibly compounding that. So anything that can potentially help to ease the itch a bit can be really beneficial for patients in terms of quality of life. I do think there is a bit of a I think when patients are saying that they're itching, there's sometimes maybe not an understanding of how bad and how much of an impact that can have on quality of life. So I think it's really important that patients are sharing that with their doctors as well, and understanding the impact that's having on them, and also try and get over the embarrassment of having it, because from a personal experience, I know it can be embarrassing, because people are looking at you thinking, she's scratching away there, what's happening there, so, and I think just to open up to your doctor and tell them about it and see what can be done to help it can make a real difference. There's a couple of questions in the room here, Dr. Bunder. So we've got one where there's a patient asking which supplements cause damage, but I think we didn't really go into specifics of which one. I think it's just a general caution overall, isn't it?
Correct. So I don't know, for example,
careful.
depends what the patients are. For example, in the US, the FDA does not regulate supplements. And there's been tons of studies showing that 85% of the times what whatever in the bottle, it says it's in the bottle, is not there. So I think just be careful, because there's not a lot of regulations for supplements, as the same as we go through medications.
Okay. And then another question in the room here, patient who's caught the end of a conversation about varicose veins and they could bleed. They've noticed some on their legs just this week. Could you explain that again, please?
So, the same you get those varicose veins in the legs, the dangerous part in cirrhosis is when they actually develop in the esophagus or the food pipe, and they can burst, they can bleed. That's a major medical emergency. So that's what I was explaining. That's someone who has a decompensation from a liver disease.
Thank you. That's great. So we have a question about balance, and is balance problem linked to PBC? So if someone's feeling a bit dizzy or their balance is a bit off, could that be linked to their PBC?
No, that's very unlikely related to PBC, unfortunately.
Great. We have another question about cholesterol. Can they ask about cholesterol, please? I know it's often higher in PBC patients, and theirs is currently 7.4. Is this something I should be taking medication for, and when should they start to worry about it? 7.4 is what it's at just now.
I don't know what 7.4 is. So I would say, again, all depends on the risk factors. So if there is no major risk factors to needing lower cholesterol medication, such as, diabetes, high blood pressure, family history, or heart attacks or strokes or kidney disease, and I would say I would wait until the ursodiol gets started and then see you trend the cholesterol over time. But again, it depends on the major risk factors. So I cannot comment until I see, that specific patient to see if they need or not need a statin specifically for the high cholesterol.
Okay, thank you. I think we have been. There's 20 minutes left. I'm not letting you away until we're at our time. I'm keeping you until 3 o'clock. Any other questions, guys? Please let us know in the comments here, and I'll keep an eye for them. But I was just thinking, we've touched on abdominal pain symptom. We've touched on itch. Thought it might be worth just touching on fatigue as well, just if we've got any newly diagnosed patients with us here today as well. So just a bit about fatigue as a symptom and options for things to look at to help with that as well.
I mean, that's a tough question to ask. Unfortunately, all the new trials have not looked at fatigue as an outcome. But what we have now is kind of, I would call it, get moving, right? So we know that exercise or movement will kind of cut that vicious cycle. I have to take a step back, when there's fatigue, and make sure to rule out some other chronic conditions. I usually check the thyroid, make sure they're not anemic. Make sure that I rule out all the other major issues. Depression is a big issue there. If you're not sleeping, you have fatigue, that actually also could be a problem too. And once I rule everything out, I usually tell patients, try to get exercise, even 10, 15 minutes, walk outside. And then as soon as you actually get moving, I see the patients actually a big difference. And again, I'm not saying you need to run the marathon within, 30 minutes. And people ask me, you're crazy. I can barely get out of bed. How am I going to do that? But I think I said, the first day take 5, the next day take 10, as much as you need. Because there's studies looking at, for example, 12 weeks of just actually moving actually makes a huge improvement in patients with PBC. Unfortunately, none of the new medications have looked into fatigue as an outcome, so I can't say for sure that new medications will really affect actually fatigue, although there is some data showing that maybe if we get that disease under control, the fatigue will go away. But I can't say that for sure now, because that's not what we have right now as evidence. So unfortunately, fatigue it's a very major, really worrisome symptom that we don't have a lot of options for it.
And I think as patients, we know there's no magic pill for fatigue, we know that. But I think even just chatting it over with your doctor and feeling that you're being heard, that it is a valid symptom that you're having, and options as to how you could perhaps help with it. We really do advocate for movement as medicine at the foundation as well. And I think becoming part of a support group can be really helpful. We also do quite a lot in terms of self-management, self-care. I think that can be really good for patients as well. I know certainly it helped for me. And I think you're right. If you tell someone who's really fatigued, it'll help if you go out and exercise. I think it's more about building it up slowly and also thinking about the benefits of actually just getting outside as well and how that can make you feel. So I think it's looking at it as part of the bigger picture, isn't it? And not just looking at it. And I do think it's important to think, could there be something else that's causing it, and just not automatically assume it's PBC as well, and maybe there is something else there. So again, I think just as what we've mentioned before is just make sure you're speaking to your doctor about that, and that you're chatting your symptoms through so that they understand how it's impacting you day to day, and if there's anything that can be done to help with that.
And again, I think, Mo, this is so important. So physicians, we are so focused on trying to get the liver test better. I think kind of empowering patients, saying, hey, listen, my symptoms are not under control. Can you do anything for them? It's as important as actually getting the disease under control. There's different tools to make this work. I think Dr. Jones has this symptoms-based clinic where he basically does it for life. But I think for us, which we don't have time, for example, I do send questionnaires the night before, and those questionnaires are reviewed in clinic with patients. And then those questionnaires basically show the fatigue and the itching there. So we can review them, and then we can basically try to give the right treatment for them. So it's so important to mention them, because if you're not mentioning them, if you don't feel that if you don't talk about them, they're not going to go away, unfortunately.
And I think the impact that we've mentioned it already, as well as the impact that itch can have on your fatigue as well, because if you're not sleeping well because your itch is so bad, anything that could potentially help with that could then in turn help with the fatigue, right, and the sleep hygiene as well. There's a question came in the room here. Patient has PBC for 2 years, responding to her so well, but now fatigue is happening more often and low in iron and B12. Is this part of PBC, and how long can I be on supplements? I think it's the B12 that they're an iron that they're referring to.
I mean, there is anemia. Again, it's just with that pieces of information, I cannot give a diagnosis. But for example, celiac disease can give you iron deficiency anemia, or an autoimmune thing can give you a B12 deficiency. I think being in the right supplements to kind of replete those vitamins, that sounds like a great plan. They're related to PBC. I would say not directly, but they can have other autoimmune ties to it. So I would just make sure that ask your clinicians, can they exclude celiac disease or other types of B12 deficiency, so that this is not what's causing the problem.
I think that's another thing that's came through today as well, is just to not assume that everything is connected to PBC, and potentially there could be something else going on there. So make sure you're telling your doctor about that, and any other symptoms that you have. We have a question on Facebook, a patient who's gone in for surgery for a lump on their neck. It's a full surgery. Should they be concerned about bleeding, as they were told patients with PBC bleed more?
The answer is no, unless they have cirrhosis. So I would say, I don't know the status of that patient, but I think, they can measure the platelet count, they can measure the coagulation factors, but PBC by itself is not related to any bleeding disorders.
No, routinely. That's great, thank you. Another patient who's mentioning that they bruise very easily. Is there anything they could use to help, such as arnica cream?
Again, the answer, arnica cream, if that works, yes. Again, I would just make sure that, relate this problem to the physicians, because I don't know if there is any issues with, more advanced liver disease or something else happening that, can cause any issues with such as a bleeding disorder.
Mm-hmm. And I think just patients being aware of different stages where they are in their own PBC journey, it could be different in terms of taking something else. So again, just to discuss that with their doctors. We have a patient who has GAVE as well as PBC, GAVE, yep. Not something I've heard before. Has the GAVE developed because of PBC, and would it cause varicose veins in the esophagus?
Great question. So this is, we know that patients with PBC can develop what's called portal hypertension. Portal hypertension is a result sometimes of cirrhosis, and that GAVE could be the result of that. Okay. So I think, I would just make sure that the PBC has not advanced to kind of cirrhosis or decompensation. And also what we know that patients with PBC can develop what's called non-cirrhotic portal hypertension. They can develop varices even without the presence of cirrhosis. So I would advise actually asking that patient to contact a physician if that's the case, because there could be difference for that. And GAVE could be treated with basically laser. They can do an endoscopy. That's a tube camera. You go inside and you burn those spots in the stomach. But again, I will advise going to the physician and making sure that's not the case.
Great, thank you. I think I'm tempted to give you 10 minutes of your time back, Dr. Bonder, because you have worked for your hour this hour. It's been really busy. We have got through so many questions. Thank you so much for that. I'm just having one last look to see if there's any other new questions that are coming in before I let you go, but we did get started a bit early today, so I think that's been an amazing session, and thank you so much for your time. There's been such a lot of different topics today as well, and such a variety of questions, and it does always surprise me that even after a few years of doing these, we still get lots of new and different questions in as well. So we really do appreciate your time. As I say, I think I've got through. I'll double check when we come off again, but if there is any questions that I've not got to, I'll make sure I get a note of them. And if you have any questions for next week, Professor Jones is joining us next week. If you have any questions for that, if you pop us an email, we'll get that included as well. So thank you so much for your time. We really appreciate it, and I hope to see you again soon.
Thank you, Mo. And again, great questions today. I think people with PBC get, I would say, spicy every time we are here. So, I'm excited to hear all this type. I love to get all this new type of questions. It keeps me on my toes, so it's very important.
Brilliant. Thank you. We really appreciate it. Take care. Right. See you later. Bye.
Thank you.